Greetings. I'm Franco Carnevali, an Italian-Canadian living in Montreal, Canada. I'm a nurse, psychologist, and clinical ethicist. And I'm sorry that I can't be present in this webinar in person live because of a time difference within Montreal. I have a schedule conflict. I'm happy to provide this pre-recorded talk called Moral Distress in Pandemic ICU Nursing, Lessons Learned and Necessary Solutions. Just before the pandemic started, I published this article in Minerva Anesthesiological called Moral Distress in the ICU. It's time to do something about it. So even before new problems faced us within the pandemic, I highlighted what are some well-known sources of moral distress within the ICU. And this was from an interprofessional perspective, not specifically nursing, where we already knew that within the ICU, many experiences of moral distress resulted from disagreements within the treating team, tragic choices over which treatment is best when all options seem so bad, having to make decisions rapidly and act rapidly, sometimes without being certain about prognosis and a diagnosis, or even what is the right way forward in terms of treatment. Tensions with administrators who determine priorities in terms of staffing and patient volume and so on. Sometimes there's tensions relating to legal standards that oblige people to act a certain way and prohibit other certain types of actions. But one thing that is clear from the beginning of the definition of moral distress is that nurses experience especially high levels of moral distress. This was first identified among nurses, and it remains the population with the most highly reported rates and intensities of moral distress. And interestingly, the experiences of nurses' experiences of moral distress is also strongly linked with relational tensions with physicians. This is in the ICU and beyond. Moral distress is defined by a situation where you know what is the right thing to do, but institutional constraints make it nearly impossible for you to pursue the right course of action. So it's very important to understand that this is not a sign of weakness of the individual, but it's what you feel when you are confronted by obstacles from acting in a right way. Moral distress is associated with feelings of frustration, guilt, anger, powerlessness, and it can result in profoundly disturbing personal experiences that can resemble what we might refer to as burnout. Now, many people, including myself, have a problem with focusing solely on moral distress because it can sometimes present nurses as weak or as deficient or not having the personal capacity to deal with the difficult demands of their work. And because we find that's a very untrue and incomplete representation of nurses' experiences. And so many of us prefer to understand moral distress within a broader concept, and that is moral agency, and recognizing that all nurses are moral agents. And as moral agents, they will experience moral distress. Moral agency refers to a nurse's capacity to engage in deliberate actions that are morally relevant, touching on matters of right and wrong, good or bad, just or unjust. Nurses are not just executors of prescriptions from physicians or instructions and directives from administrators. Nurses are expected to continually assess and judge what is right and wrong and act accordingly because they are professionals. Nurses are moral agents that are continually striving to do good, and it is therefore understandable that when they confront obstacles, barriers to acting in a good way, that they will experience moral distress. Now let's look at nursing, nurses as moral agents who can experience moral distress, and what that looks like in a pandemic context from what we know so far. Early in this pandemic, the COVID-19 pandemic, Morley and her colleagues published this article where they highlighted 3 broad ethical issues that nurses face that could provoke moral distress. And that is constant concern about safety of self as nurses, of patients, colleagues, and families. Challenges regarding the allocation of scarce resources for care, but as well as scarcity of personal protective equipment. and also the significant changes in the nature of nurses' relationships with patients and families, particularly because of the requirement for distancing measures. In my own work as a clinical ethicist, I've listed here what I've seen as some of the difficult ethical challenges that could lead to moral distress that nurses faced within the COVID-19 pandemic. And I'm not going to go over them in detail here, but these relate to concerns about personal safety, patient and family safety, uncertainty about viral transmission and its treatment, problems with access to life-sustaining care, as well as access to non-pandemic services, such as nurses who have children having difficulty accessing childcare. Problems with so-called visiting policies that impose restrictions on the presence of family members. Sometimes also the pandemic amplified pre-existing inequities and injustices where access to needed services became even more difficult by populations that are disadvantaged. Widespread social impacts relating to grief and loss, isolation, economic stress, childcare problems, and homeschooling, among many other types of ethical concerns. More specifically, we've also highlighted some of the particular challenges that have been faced by nurses within the pediatric ICU, and I refer you to a new issue published in the journal Pediatric Intensive Care Nursing that is published by myself and Irene Harth as the co-editors, where we have published in 2 successive years a total of 17 narratives from nurses around the world working in pediatric ICU that echoes the stresses that I've already listed before. I don't have time here to go into detail, but I invite you to read our issues where we highlight specific challenges of being a pediatric ICU nurse within this pandemic. But what we also see in those narratives is not only moral distress, but the very inspiring and courageous actions mobilized by these particular nurses, where, for example, they rallied to find ways to maintain contact between children and their families, despite the obstacles created by the distancing measures. They made many personal sacrifices in order to help each other out and to help children and families, and they stepped up in all kinds of ways to do hard things to navigate the challenges that were presented by the pandemic. With all that we know that nurses have been facing, and with all that we know about many, many difficult types of moral distress that nurses have been facing throughout this pandemic, what have we learned, and what should we do about moral distress in relating to pandemic ICU nursing? This is a literature that is still being shaped, is still being formed. A lot of people are doing very thoughtful work. And so I am drawing on my own experience as a clinical ethicist throughout this pandemic, as well as the bit of literature that we have available to us to try to map out ways forward from the lessons that we have been learning so far. I want to highlight that research is urgently needed to really further examine which strategies are most effective for addressing moral distress. And I highlight for you 5 actions within an action plan that I'm going to describe it to close off this presentation. First of all, moral distress is a very individual experience, and it's important that you listen attentively to your colleagues' moral distress. I think of moral distress as just like pain. Do not try to convince the person who says they have pain that they don't have reason to have pain. Similarly, if someone is experiencing moral distress, it is made worse when people are told they have no reason to feel it. Listen attentively, try to understand it, and there, see if you can together identify what are the obstacles that that person is facing, or if it's yourself, what are the obstacles that you are facing, and what can be done about those obstacles. Let's also make sure, number 2, that personal supports are available to persons who are experiencing moral distress. And those supports could be working together to mobilize, to manage the barriers. Those supports could be making sure that if persons need some time off, that they can get some time off, and that they will not be blamed for that. Sometimes some people might require some professional psychotherapeutic or other types of supports. And access to that has to be made available to nurses who are facing such difficult hardship. We have to recognize that nurses are moral agents. That is, I think, foundational, because that is showing respect for the dignity of nursing as a profession. That do not consider nurses merely as executors of actions that others make and just carry out those orders, and you should not have to feel something. So it's important that nurses are recognized as professionals who are engaged in complex clinical judgments and actions. Organizational support is needed. We cannot put it all on nurses' shoulders to have to resolve moral distress. The most important problems relating to moral distress is the obstacles that nurses are facing. And those obstacles often require administrative and other types of organizational mobilization to really help to diminish the obstacles that nurses have to navigate in order to practice professionally. And then in closing, we need to create spaces for ethically attuned discussion, where nurses can discuss their moral distress openly in a professional manner, and that we ensure we have ongoing educational sessions wherever we can, even during a pandemic, to make sure that we are all learning about moral distress, nursing agency, and moral agency, and that we promote it optimally despite the difficulties. And toward that end, there are some pandemic models and standards that can help us better understand moral distress in the face of a pandemic and how we could reconcile some of the ethical concerns that arise. And I will just list some of these for your information, and you can use either my slides or you can email me for further information. The Canadian Nurses Association published this statement early on in the pandemic, highlighting ethical considerations that need to be worked with within a pandemic. And what they did was they highlighted some key questions and how they should be addressed within the context of a pandemic. And many nursing organizations around the world have done likewise. Turn to those within your setting to see what guidance they can offer. For example, within Italy, the professional nursing order, the National Professional Nursing Order, published this statement that highlighted nursing ethics, a definition of nursing ethics within the context of a pandemic. And it is very striking to see that right from statement number one, they acknowledge that nurses are active agents. And this is an important recognition of nurses as not just workers, but as moral agents. We also can draw from various tools, models, and frameworks that can help us analyze different types of situations as ethically problematic. And so this one by Emmanuel and colleagues highlights ethical values and guiding principles that can help us identify what is the best way forward, and if there is no good way forward, what is the least bad way forward. Likewise, Allison Thompson et al. Published this framework. That is the one that I work with. This was developed after the SARS pandemic many, many years ago. But I find it extraordinary as it highlights key foundational values as well as ethical processes that should be mobilized to help us prepare for and navigate the context of a pandemic. These are useful, absolutely valuable tools to help us analyze how to act right in the context of limited options and urgency of a pandemic. And so with that, I close. I thank you. And I look forward to a dialogue that we might have through email. Do not hesitate to contact me. And here's also my website on where you can see some of the publications of our work in childhood ethics. Thank you very much. Grazie mille. Merci beaucoup.